Greetings, everyone, and welcome to the EKG case for the week of May 6, 2012. This is Amal Mattu from University of Maryland, and this week's case is a good bread and butter ST segment elevation case. We're going to kick things off. As a 43-year-old man that presented to the emergency department complaining of chest pain and shortness of breath. So it's the kind of thing that you and I see in the emergency department probably all the time. And we are oftentimes trying to debate, is this, well, we'll go through the differential of the various causes of ST segment elevation. Of course, STEMI is the one that we worry about the most, we lose sleep over as well. Let's first of all talk about the rhythm before we get into ST segment elevation. And this kind of is a little bit of an extension of what we talked about last week. If you look at the rhythm down there in lead 2 at the bottom rhythm strip, what you might be noticing is that there's these little extra blips, and we established last week that blips is the technical term for these little extra beats that you see in here. And in fact, in multiple other leads, take a look at lead V3. You've got those blips in there as well, and up in lead 4 and in lead 5. And as we mentioned in previous weeks, whenever you see extra blips or extra stuff, that's the other technical term, extra stuff in the rhythm, you've always got to wonder, are those extra P waves? And in this case, we'll take a look at lead V3 just for the heck of it. Lead V3, there's definitely a P wave there, and then there's something there, and I don't know what that is, and then there's a P wave, and there's another question mark there. Well, if you want to know whether those are P waves or not, what you simply do is you get your calipers and you map it out, and if they map out regularly, then you have to assume that those are P waves, just like we established last week. And it turns out that when you map these out, they do not map out. So those are not extra P waves. It's simply, I don't know, artifact or other stuff, miscellaneous stuff. I'm not really sure exactly what's causing those little extra things, stuff, blips, other technical terms for those things. But again, I think it's good to always be a little paranoid when you see those extra blips in there and get your calipers, map them out, because it may be extra P waves. And if those are extra P waves, you're looking at a second degree AV block with 2-to-1 conduction, right? But in this particular case, you took the time to map it out. They don't map out. And so that turns out to be just artifact. And to be honest with you, totally honest with you, I don't know what those are. Maybe the patient was twitching or something like that. I don't know. But I'm not going to worry about it because they don't seem to be affecting the rhythm. And most importantly, they don't map out with the blips that we know are true P waves. Okay, so enough about the rhythm. This is just sinus tachycardia. But I did want to address those extra blips in there since we've been talking about extra blips over the past couple of weeks. The main reason to present this case is to focus on ST segment elevation. And you'll notice that there's a whole heck of a lot of ST segment elevation. There's ST elevation in the limb leads. There's ST segment elevation in the precordial leads as well. So a lot of ST segment elevation. So let's briefly just talk about the differential for ST elevation. We've done this before. We'll do it again. We'll do it again over and over in the future because this is such a critically important part of our specialty in emergency medicine. You've got to know ST segment elevation. You cannot miss STEMIs in our society, and frankly, it's just bad for the patient also. So, first thing that we always worry about, number 1, number 2, number 3, you got to worry about STEMI. So, is this a STEMI? And then the other common mimics, benign early repolarization, pericarditis certainly is a mimic that occurs in patients that present with chest pain. And then there's a handful of other conditions which are not necessarily associated with acute chest pain. LVH may be a chronic condition, left bundle, pacer. Whenever you mention left bundle, you always throw pacer in the differential as well. Brugada syndrome, which we've talked about before, these are patients that usually present after syncope, usually are not actively having chest pain. It's more of a syncope, pre-syncope. Ventricular ectopy, or PVCs, can often produce ST segment elevation. And then there's a handful of miscellaneous, less common things. PE can produce ST changes, not that commonly, but it can. Hyperkalemia, we refer to as the great imitator, or the syphilis of electrocardiography, because it's an imitator. And you know what? Stroke is also a great imitator as well. Hyperkalemia and stroke are well known and well published to produce just about any abnormality on the EKG. ST elevation, ST depression, new bundle branch blocks, tachycardia, bradycardia, whatever you can think of. Hyperkalemia and stroke have been reported to produce those things. So you'll always put those in the differential. It's kind of like when you're on internal medicine rounds, you always put amyloid, sarcoid, and TB in the differential. And when we're talking about electrocardiography, you always put hyperkalemia and stroke in the differential. You'll always look smart if you do that during teaching rounds. Okay, so that's our differential for this particular condition. Let's go back to this case, take another look at it. You'll notice that there's no evidence of a left bundle, so we can get rid of that from the list. It's not a wide QRS. There's no pacer spike, so we'll get rid of that. These are not PVCs or ventricular tachycardia. We can get rid of that. There's no ST elevation in V1 or V2. There's not that incomplete right bundle pattern with the ST elevation. That's a bad drawing, but in V1 and V2, that's what you'd, let me try that again. RSR, that's a little bit better, but that's what you'd expect to see with Brugada, so we can probably get that off the list as well. Let's go back to our list. Okay, we can get rid of left bundle, pacer, Brugada, ventricular ectopy. PE, you know, it is kind of an imitator, but we're going to get rid of that because there's no signs of right heart strain. Remember the signs of right heart strain: flip T waves in the inferior and anteroseptal leads, and other signs of right heart strain would be a right bundle or an incomplete right bundle in V1 V2. There's no S1Q3 T3 or rightward axis. So you know what? I'm going to get rid of PE. Hyperkalemia, there's no big peaking of the T waves and there's no widening of the QRS. So we're going to get rid of hyperkalemia as well. And we're going to get rid of stroke simply based on the history, because I'm not trying to trick you. I didn't give you anything about stroke symptoms here. So we can get rid of that. What about LVH? LVH is a tough one. You've always got to keep that in mind. This person has fairly high voltage and might just come close to meeting the criteria for LVH. For example, if you add the S wave in there with the R wave in there, maybe you're going to get up to 35 millimeters. But usually LVH that produces ST segment elevation produces the ST segment elevation just in the right precordial leads. It's not typical for LVH to produce ST segment elevation in the lateral or in the inferior leads. Usually it's just in the right precordial leads, usually, but good enough. I'm going to get rid of LVH from this list. So essentially what we've got is a very common quandary. Is this ST elevation, MI, is this benign early repolarization, or is this pericarditis? All right, so when you're trying to figure those things out, there's some simple techniques that you can do. Number one, you look at ST segment morphologies. I think we've mentioned this before, but when you've got STEMI, if you see ST segment elevation that's horizontal or convex upwards like a tombstone, it's got to be a STEMI, all right? So do we see any horizontal or tombstone type of ST segment elevation? There's really not. All of the ST segments seem to be somewhat concave upwards. The way I think of it is if you put a drop of water right in there, would it immediately spill out or would it kind of sit there? And I think in most of these leads, it would kind of sit there. Most everything that you're looking at, pretty much everything you're looking at, is fairly concave upwards. V1 and V2 are kind of tough. They're kind of straight, but maybe just a little concave upwards. If it's too close to call, don't read too much into it. So what we're going to do is we're going to say that all of these all these ST segments are fairly concave upwards. Even the ones that are going straight up are just a little bit concave upwards and not more of an oblique type of pattern. I hope you can appreciate those morphologies that I'm drawing there. So there's no concave upward or horizontal ST segment elevation. The other thing that you can do is compare the ST segment elevation in lead 2 and lead 3. If the ST segment elevation in lead 3 is greater than in lead 2, that means you're looking at a STEMI. All right, so ST elevation in 3 greater than 2, that's got to be a STEMI. In this particular case, ST elevation in 2 is greater than in 3, so we can't even use that rule. Okay, what else? PR segments. Let's look at some PR segments. Do we see any PR segment depression anywhere? Or any PR segment downsloping? And I don't know. I think I'd have to imagine PR segment depression or downsloping. And if you have to imagine something, you know what? Don't call it. Don't read too much into it. So the bottom line here is you really don't see any good ST segment changes which guarantee this is a STEMI, and you don't see any PR segment changes that guarantee you're looking at pericarditis. So looking at the ST morphologies and the PR segments, we don't have an answer. Next step, you want to really try to look for old EKGs in this particular type of case. Take an extra 5 or 10 minutes and track down an old EKG. If the old EKG is identical to what you're looking at now, then that means it must be benign early repolarization. If the old EKG is different, then you just ruled out benign early repol, and that means you're looking at STEMI versus pericarditis. And I'll tell you what happened in this case. We got an old EKG, and the old EKG, which I don't have for you, but the old EKG was rock solid normal. There is no ST segment elevation. So it's changed. And so the old EKG compared to now, it's changed, and that rules out early repolarization. Okay, so now we're down to two possibilities. What can we do now? The ST segments have not helped. Old EKG has at least ruled out benign early repol. What about serial EKGs? Well, that can be helpful as well. If you have time, get serial EKGs. I'm not talking about every hour. That's too long to wait, because if it turns out to be a STEMI, you're losing myocardium. When I say serial EKGs, what I'm talking about is every 5 or 10 minutes. Get another EKG in 5 or 10 minutes, and then another one in 5 or 10 minutes, another one 5 or 10 minutes. Now you're only 15 minutes to 20 minutes into the case. If you see any evolving changes during that first 20 minutes or so, it is in all likelihood a STEMI. Maybe those ST segments are going from that. Maybe they're starting to do that. And then maybe eventually they start becoming oblique within the 5 or 10 minutes or so. That means it's a STEMI. Maybe those ST segments are starting to drop. Maybe you're starting to get some reciprocal ST changes. That also tells you that you're looking at a STEMI. All right? Maybe the T waves are getting, instead of normal T waves, maybe you're starting to get these hyperacute looking T waves. Or maybe they're starting to get very oblique at the beginning. We've talked about that in previous video casts before as well. Any changes in the ST segment or the T wave, that's got to be a STEMI. So that can be very helpful as well, and you're only losing about 15 minutes or so. In this particular case, serial EKGs did not help at all. So that's not helping. Pericarditis is not going to change. STEMI often will, but not necessarily. So if your serial EKGs are not changing, well, you still don't have an answer. Next thing that you can do is to try to get an emergent echo on the patient. If you get an echo and you see wall motion abnormality, that points towards STEMI. If you see no specific wall motion abnormality, but you see pericardial effusion, then that points more towards pericarditis. And then, when in doubt, when you don't want to waste any more time, you know what? There's no reason to be a cowboy here and make all the decisions on your own. Call cardiology, get them on board, get their eyes looking at the 12-lead EKG, and get them to work with you on this case and discuss the case, get them on board, and some of the cardiologists are going to say, you know what, with that EKG, let's get a couple more EKGs, maybe a troponin in 1 hour, and see what happens. And some cardiologists are just going to say, you know what, let me take them to the cath lab and find out for sure whether there's an acute thrombotic occlusion or whether this is just pericarditis. And that would be a very, very reasonable thing to do. Getting cardiology involved is very important, because if it turns out that you've made a mistake, it's always better to have other people on board with you. It's a lot more defensible if you've gotten help and more than one person made the mistake. That just verifies that it was a really, really tough case. Okay, so to recap here, we got an old EKG. It was different, and so benign early repol is ruled out. Serial EKGs didn't help. We were able to get an echo. It took a little while, and we weren't at this particular case. I wasn't working at a hospital that even had cath as a possibility, So we got serial EKGs, and then we got the echo. And you know what the echo showed? It showed a big pericardial effusion. And so this ugly, ugly looking EKG, it turns out, was nothing more than acute pericarditis rather than a large MI. Clinically, it was not an easy call because this patient looked really, really sick. He looked extremely uncomfortable. And so it could very well have been a massive MI in this particular case. It was not clear, but I thought it was an interesting case because it just kind of walked through the differential for ST elevation and also the decision making that you need to use when you face these conditions where the diagnosis is not clear using some of those simple rules. So anyway, hope that helps. The key takeaway points again, with the differential for ST elevation, go through the different possibilities and knock them out one at a time. And when you end up with those three bugaboos, the pericarditis versus early repole versus STEMI, get an old EKG. That'll help knock out benign early repole. Take a good close look at those ST segments and the PR segments. That might help clarify things, but if it doesn't, then you've only got three things. You've got serial EKGs, you've got a quick echo, or you've got cath. And sometimes you may need to send them all the way to cath to get the answer. So anyway, I hope this case was enlightening, and I look forward to talking to you next week. Thanks a lot.